Dissociative disorders in medicine and psychiatry. Dissociative disorders are a silent, worldwide epidemic. The most familiar clinical presentation, previously called multiple personality disorder and now called dissociative identity disorder, is only one of several forms of dissociative disorders. Though previously thought to be rare, even dissociative identity disorders have been shown to affect more than 1% of all people and more than 10% of psychiatric populations worldwide. These disorders are frequently overlooked or misdiagnosed, even though they represent a valid and distinct diagnosable clinical entity. They are responsible for a significant burden of disease due to the physical, mental, and social disabilities that accompany them. Because dissociative disorders are associated with severe early childhood trauma and child abuse, research remains complicated contextually. The discoveries made during therapy are often very disturbing for both patients and therapists. As such, the condition elicits mixed attitudes ranging from outrage to denial. However, irrespective of scientific, medical, or even theological controversies regarding the etiology and most effective treatment, the need to prevent childhood trauma as far as possible and to assure early detection and restoration of these affected individuals is certainly not in dispute. The challenge is achieving collaborative consensus on how to do this. Also central to the management of this condition is offering hope, assuring safety, and preserving human dignity. The survival mechanism of dissociation and fragmentation of consciousness, memory, identity, or perception of the environment are only overcome when the abuse stops, safety is maintained, and the amnestic barriers to the traumatic events of the past are lifted. Therefore, the primary goals of this presentation are to increase awareness of the disorders, to provide empirical evidence for their validity, to emphasize that safety is a priority, that trauma work is mainly aimed at removing the defensive amnestic barriers that were erected in self-defense to keep unimaginable pain isolated from the rest of the person, but at the expense of a partial loss of self and dysfunction in later years. To show that integration, although preferable, is not compulsory for recovery or function, and to emphasize that the actual target for therapy is the dissociation response itself. And this is also why this diagnostic category is justified. Lastly, it is not primarily about the physical and psychiatric co-morbidities, even though it is usually these that first bring the individual to the attention of the healthcare system. Unfortunately, this often misdirects efforts towards symptomatic relief rather than towards addressing the dissociative components. This is the overview of topics I will be covering to a greater or lesser extent under this topic, Dissociative Disorders in Medicine and Psychiatry. A brief introduction, overview of dissociative disorders, neuroimaging findings, relevant psychopharmacology, neuromodulation, and partnering, particularly between health professionals and communities of faith. As is customary for medical and scientific lectures, I would like to start by offering a disclaimer regarding any relationships or factors that may potentially affect the objectivity of the material I'll be presenting to you. Perhaps the most important one here is to admit quite frankly and upfront that I'm not a credentialed expert in this field, nor is it my primary area of study or practice. I'm not a mental health practitioner, counselor, or pastor. My views are not the product of psychiatric training or practice, and they are therefore not offered in any arrogance, nor am I driving any particular agenda, medical, religious, or otherwise. My primary medical training and academic background is that of a general medical practitioner, licensed to practice in South Africa and the United States, with a Master's of Science degree in aerospace diving and hyperbaric medicine. There's a lot more information on my webpage, including links to various other lecturing materials, which are all available on YouTube. I work part-time at the Stellenbosch University Medical and Health Sciences faculty at Tygerberg campus near Cape Town. This topic is not presented in any formal academic capacity, however, and my views do not necessarily represent those of the university. I also have a sessional medical officer's appointment with the Western Cape Government Emergency Medical Services, where I serve in the capacity of Associate Medical Director for the Baramedical Facility. Again, I'm not representing the government or the Department of Health with this presentation. I'm one of the inventors of a so-called nutritional kit used to mitigate known risk factors for multiple sclerosis. However, my topic today does not relate to this in any way. So why am I talking about this at all? Suffice to say here that a combination of personal, professional, and psychospiritual reasons have compelled me to study these disorders in greater depth. Partly it has been the result of my own frustration in trying to help people suffering from it. Partly it's also been because of my witnessing the failure of current bio-neuropsychospiritual theories to account for or to adequately reconcile the various observations and anomalies I've encountered firsthand in my life and medical practice. In my experience, oversimplified approaches or stand-alone therapies aimed only at one of the biopsychosocial spiritual domains either fails completely or it produces inconsistent and very often only temporary improvements. Simply stated, nothing less than the full investment of our own humanity, bio-psychosocially and spiritually, are able to truly assist those whose humanity have been lost or fragmented through severe developmental trauma. Anything less than this falls short. This requires true involvement, not only intermittent or spurious interventions. And in all fairness, our overburdened healthcare systems were simply not designed to deal with this, and cannot be expected to provide the consistent care these conditions demand. Nevertheless, the process of recovery often only starts once the problem is correctly identified. Without awareness, nothing happens at all, or worse, harm is actually done. So my plea to medical colleagues is for greater awareness, and my plea to communities of faith is for greater involvement. In support of this plea, and to address some of the medical and to some extent the religious and spiritual issues surrounding these conditions, I will be offering some of the outcomes of recent scientific and medical research. My aim is to offer greater clarity and to actively encourage dialogue, to establish more functional collaboration, particularly between the healthcare sector and the various communities of faith, who, as I mentioned, are actually far better equipped to offer ongoing personal support than the clinical healthcare systems are able to provide. To achieve this type of dialogue and trust, however, the pitfalls of superstition and scientism must be addressed. What do I mean by this? In essence, it comes down to the following. Whenever we attribute the causes or effects of these conditions exclusively to either purely spiritual or purely physical factors, we inevitably create a therapeutic dichotomy. This means that we set our patients up for rejection, and it usually forces them into an either-or decision between medicine and ministry. Moreover, because dissociative disorders often emerge in the wake of severe ritual abuse, transparency and trust are critical to safety and ultimate recovery. On the medical side, arrogance or denial are common barriers to providing timely and appropriate protection and the help these individuals need. On the spiritual side, there's a distinct danger in attributing biological abnormalities or psychological constructs to external evil spiritual forces. This is not to say that there are no such evil or spiritual influences, but if, for example, a fragment of the psyche of an individual is now classified as a demon or evil spirit, the ensuing remedy of exorcism or deliverance is diametrically opposed to traumatic memory recovery, co-consciousness, and ultimate integration of that part. On the other hand, integrating an external spiritual influence would also be unhelpful. So trust, dialogue, and humility are essential for this work to be successful and flexible as the situation changes and new issues emerge all the time. For those who entirely dismiss or struggle to accommodate the non-material aspects of our humanity, I would just like to quote Rupert Sheldrake, in which he says, "Everyone agrees that the mind and the brain are closely interconnected, but this does not prove that the mind is the brain." And indeed, few human conditions challenge the extremes of superstition and arrogance as much as dissociative disorders do. As a result, and depending on a person's foundational worldview, there's a tendency to either insist on some undiscovered mechanism or to presume a metaphysical explanation whenever reason fails us. And just to offer a relevant case in point, which also partly explains my interest in this area. I mentioned previously that my academic background is aerospace diving and hyperbaric medicine. In each of these spheres, there are circumstances that produce altered states of consciousness, out-of-body and even near-death type experiences. Now, this in itself is not surprising or unique, but the individuals in question are typically physically fit, unlike the usual situation in psychiatry or medicine, and therefore the recoveries are quick and recollection of the experiences are typically immediate and usually easier to record and perhaps arguably more reliable. For instance, in high-altitude aviators and cosmonauts, part of their training involves deliberate exposure to low partial pressures of oxygen. This basically allows the participants to experience low oxygen and loss of consciousness. In pilots of high-performance aircraft, on the other hand, there's the effect of acceleration or G-forces. These are also introduced during training by means of human centrifuges to the point of unconsciousness due to loss of circulation to the brain. And on the other side of the spectrum, there are breath-hold or compressed gas divers who experience low oxygen, narcosis, and even psychedelic effects related to the various breathing gases. So quite apart from anesthesia, resuscitation, and psychiatric literature, my field of study is also replete with accounts of dissociative, out-of-body, and near-death experiences. This is an excerpt from a National Geographic documentary called Moments of Death. It examines both the phenomena and the evidence surrounding near-death and out-of-body experiences, which are on the dissociative experience spectrum.
In the 1970s and 80s, a possible answer for why near-death experiences occur came from an unexpected place.
The United States Air Force had new aircraft, F-15s, F-16s, and those had high sustained acceleration or G-forces. We worked on ways to enhance their tolerance to acceleration so they could gain an advantaged position in combat.
Air Force Major General James Winery was studying the effects of extreme G-forces by spinning pilots in a centrifuge.
A centrifuge spins around, similar as to when you have an aircraft that makes very tight maneuvers, getting from 1G to 9G in a little less than 1 second, which means if you weigh 200 pounds, in a little less than 1 second, you're going to weigh 1,800 pounds.
Push it out, push it all the way up, all the way up.
Under this kind of stress, the pilots blacked out when the G-forces prevented blood from reaching their brain. This result was no surprise. But then things got strange.
3, 2, 1, pressure.
Some of the things that we were finding were seeing a bright light, seeing family and friends, familiar scenes, what would be considered out-of-body experiences, that they were above themselves, looking down at themselves.
Winery and his pilots were momentarily deprived of oxygen, but they were nowhere near death. The major impact of Winery's experiment is that it strongly suggested near-death experiences weren't some sort of mystical phenomenon, but the result of extreme stress on the brain.
As the brain gets closer and closer to death, the brain starts to only fire in areas which are very, very basic to survival. Closer and closer to the brain stem. That's a very small and very fundamental and primitive part of the brain. So the visual cortex, the back part of the brain, or the superior colliculi, which is considered part of the brain stem, if they are activated, all you see is light. And so to see a light with a lot of darkness around it, our best interpretation is that's a tunnel. And we are attracted, because we are mammals, we are attracted to light.
Although it would appear to suggest that the experiences of near-death are simply due to the mechanism of withdrawal of blood and oxygen from the brain, this actually does not address, for instance, why these experiences are often so meaningful, or why people's recollections of these experiences are so vivid, coherent, and frequently life-changing. Neurologically speaking, it's quite plausible that residual function in the midbrain primes individuals for a bright light and a tunnel experience. However, this does not abrogate an equally valid ancient mystical understanding about the core of our being or the breath of God. In fact, the life review many people experience could actually support that the seat of the so-called hidden observer of our lives might be situated in the midbrain. Such complementary understandings should actually encourage dialogue rather than the reverse. In all fairness, though, I certainly admit that clearly this is not a neutral subject. There are significant philosophical and religious implications, not to mention the overt challenge to the prevailing theories of mind. Perhaps also, and I include myself in this, as professionals and scientists, our natural curiosity becomes conditioned by skepticism and sometimes even cynicism, as the sacred mysteries of old are reduced to secular mechanisms by irreverent scientific methodology. Therefore, we secretly fear to be deemed fools, naive, gullible, or even superstitious. So we choose to hide under fig leaves of arrogance, collective prejudice, or denial. Quite apart from being an affront to conventional science, most people also have a visceral aversion to the subject of death and discomfort about any concept of spirits. For instance, for an atheist, it challenges disbelief in an afterlife. For a theist, it provokes a greater sense of accountability and judgment. For the Gnostic, it may erode hopes of ultimate spiritual freedom. And for the agnostic, it encroaches on a disinterested neutrality. And for all of those who acknowledge some form of either possession or reincarnation, the danger of intrusion or the futility of escape. The net result of all this is that science remains aloof and personal beliefs remain unchallenged. Still, it would be scientifically dishonest to ignore or dismiss out of hand the significant body of evidence for soul-mind fragmentation and transmigration phenomena, as well as the nearly universal human experience of some level of interaction with spiritual beings, including previously deceased individuals.